So we're gonna talk primarily about how to manage depression and how to treat it in the primary care office. So why don't we start by just having you guys let me know, when do you screen for it? How do you know when to ask those questions? Don't everybody jump out at once. So do you do it to everybody, or what raises your level of suspicion for asking somebody how they're feeling? Okay. Gotcha. So ask if you have non-specific complaints. Lead with the PHQ-2. I'm sorry? Yes, Medicare physicals. Good. Okay. So they just look like they look sad, or just not like they're all there. That's great. And actually, the guidelines for when we were supposed to screen just changed at the end of January. So the standard up until January 26th was, if you suspect depression, you should check for depression. Now it is that we should screen everybody that walks in the door, as long as we can provide those services. And the U.S. Preventative Services Task Force said that we now have adequate mental health coverage in this country that we can do that, which, if you guys have seen our wait list in the clinic, I think last time I checked, this last week, it was like 700 deep. So what that means is that you guys are going to be screening for depression, and you guys are going to be treating depression. And then only when things get pretty far down the line, you run out of treatment options, they just seem like they're resistant to treatment, then that's when they're going to be referred to us. The previous guidelines were, you use a standardized screen, and then you screen based on their presentation or if they have risk factors. So, like we said earlier, there are many different ways. People aren't going to walk in your office and say they're depressed. They will sometimes. But the people that you should be looking out for are frequent visitors. So they're having, a visit every other month. If they have symptoms that just don't seem to fit with anything else, sleep disturbances, fatigue, kind of these general non-specific complaints, that's when you should be asking about, psychiatric history. You should be asking about depression. You should be asking about anxiety, substance abuse. And then, of course, there's the big one with irritable bowel syndrome. We now know much more now than we did 15 years ago that the gut and the mind are very closely linked. And about 50% of people with IBS wind up coming to get treatment in the clinic. And of those 50%, about 50 to 75% have a psychiatric comorbidity. And once we see their depression or their anxiety treated, we see that their IBS gets a whole lot better. So it makes your job easier, it makes our life easier. So, yeah. And you should always screen. One thing that's not on this list is that if you're talking to a patient and they've had a big life event, that's, a death in the family, a divorce, change in job, whatever, that's a big cue that you should be asking, because a fair percentage of first events, first depressive episodes present after a major life change. So how do we screen? There are many screening tools out there. Probably one of the first places to start is just by using a PHQ-2, which you've got two questions. Have you been feeling down, hopeless, depressed? And have you had little interest in doing things? So these are those two major criteria, depression and anhedonia. If you have yes to one of those things, that should clue you in that you need to ask more questions. So you can do that by just going through the DSM criteria. That's the old SIGI CAP stuff. Have you had these symptoms for more than 2 weeks? Or you can go ahead and you can hand them a PHQ-9, and you can have them fill it out. So there's kind of a different, and if you kind of suspect that there's going to be an issue on the front end, especially I think what's probably going to be changing now with the guideline changes is I think I have a feeling that most of our patients on both sides are going to be given these forms before they even hit our door, hopefully. So we'll be able to know, if we should be asking these questions or not when we see them in the office. But, the DSM criteria is you got to have depressed mood or anhedonia, then you got to have 5 of the other symptoms. So that's, change in weight, change in energy, change in appetite, difficulty concentration, fatigue, psychomotor agitation or psychomotor retardation, those kind of things I'll remember from medical school. So I would recommend picking a screening tool and sticking to it, just so you have familiarity with it. I wound up using the PHQ-9 the most. A lot of the studies will use PHQ-9 or the Beck Depression Index or the Hamilton Rating Scale. They all have evidence that shows they're valid. So it's really just a matter of picking one and staying with it, and then using it each time you follow up with a patient. Because you'll find that, they'll come back in 2 months and say, well, my depression feels a little bit better. And then you do a PHQ-9 or you do a rating scale, and they see that their point has only, they've only improved by 1 point, 2 points. So even if they say they're doing better, there's a really question of, are they doing that much better? Or sometimes they'll tell you that they feel horrible, and then you'll give them a rating scale, and they rate like a 5 or 6. And then, it shows that's something really mild. So then you can kind of explore with them, where is the discrepancy between what you're describing and these symptoms? And one of the big changes in the task force guidelines is that we should be screening all adults. So that includes, of course, pregnant women and postnatal women. So the Edinburgh is the most common one you see used on, on the maternity ward. So we screened, we figured out this person is depressed. Where do we go next? So this person's sitting in your office. Probably the first thing you want to do is you need to figure out, okay, what is going to be the most appropriate level of treatment for this guy? Is this going to be a person that I'm going to, send out with just, tell him to improve his diet, maybe exercise some more, think about seeing a therapist and following up in a month? Or is this a guy that, is telling me that he's hearing a voice that's telling him to kill his wife, and he's never been this depressed before, or he's sitting there in his own urine, or he's, telling you that he just, almost drove his car off the bridge on the way to the doctor's appointment. So that, before he leaves the door, you need to document, and you need to figure out what's going to be the appropriate level of treatment. So, we've got medication. We can follow up with you guys. We can send him over to EPS. We can, make a referral to intensive outpatient or partial hospitalization. Some of those things don't actually need to be done through, if you feel like this guy is really depressed but isn't suicidal, doesn't need to go in the emergency room, you can send him directly over to the Brook or Our Lady of Peace, and they can get an evaluation there for like one of their partial hospitalizations. So you kind of need to figure out, okay, is this guy going to be safe to go home and sleep at home and follow up? So you want to, I always, if it's someone I've never seen before, a lot of times I'll frame the interview and say, they're telling you how they've been feeling. I'll say, it sounds like things have been really rough. Does it ever feel so bad that you just feel like not going on? So I usually lead with something like that instead of, do you ever have thoughts of wanting to kill yourself? Especially if it's someone who's never seen a psychiatrist before. A lot of times that can be frightening that someone's suggesting that to them. So based on their thoughts, based on what they say, you say, well, I feel so down. Sometimes I just wish I wasn't around. Then from that, you can kind of explore, okay, have those thoughts ever gotten to the point where you feel like hurting yourself or taking your own life? And so you really need to kind of figure out, okay, is this guy actively suicidal? I mean, I think we have probably all had thoughts of just wishing, usually the day before an exam, that like a meteor would fall out of the sky and hit us in the head and we wouldn't have to take this test tomorrow. Or maybe that's just me. But, that's different. Like that person doesn't need to be sent over to, EPS. Because every once in a while we'll get someone that shows up from EPS and it's not, just referred. It doesn't matter which department it's referred from. And they'll get really freaked out that they got sent over there. And, the story kind of changes of, why they were sent there. And, the guy will say, well, I was in a lot of pain. And sometimes I just say, like, the pain's not worth it. I just feel like dying. Like, that's, that is not the kind of suicidality that we're really worried about, that we got to keep them locked in an inpatient unit. So you need to kind of really try to pin him down on what his thoughts are. So does he have a specific plan? Does he have intent? Big one is access to weapons. So if this is a guy that has a bunch of guns at home, even if he's a little bit depressed, if he's not suicidal, you need to make the recommendation that he get the guns out of the house until he's feeling better. Just having the guns in the house increases his risk of suicide. And we know that guns are the most lethal way to do it. So it doesn't matter where you stand on, where you think the place of guns are. If you're depressed, guns really shouldn't be around you. Inquire about recent suicidal behavior. This also includes, someone who's, if you see someone in the office that's got a bunch of superficial cuts, you should always ask, why are you cutting? Are you cutting because it feels good? It relieves stress? Did you cut because you tried to kill yourself? And then when you're asking questions about, suicide attempts, I tried to hang myself. Well, did they try to hang themselves with dental floss or, like a dog chain? Because sometimes the level of, their desire to kill themselves doesn't quite line up with how they tried. So you got to kind of weigh those options. One thing you can look at is what's going on in their life. So what's stressful? What do they have to live for? So we know that people that are married or that have, close family ties, that have children, that have siblings, that have a good relationship at work, that are spiritual, religious, those things are protective. And those things are going to be, good ways to feel better about sending them home. Family history is important. Anytime you've got a family history of suicide, it increases your own risk of attempting and committing suicide. And then for not just hurting themselves, but hurting other people, you want to ask about a history of violence if they've had assaultive behaviors in the past. Is this a person that's had a bunch of DVOs, beat his wife, whatever? That's a really important thing to document. So you're trying to figure out at the end of this, is there an imminent risk to this guy or other people he's around? The other part of assessing risk is that you want to screen for other, psychiatric illnesses. So things that are going to clue you into the fact that this is going to be a more difficult case to treat. So substance abuse, alcoholism. You got to ask those questions about bipolar disorder. So, one thing we're concerned about is you've asked all the depression questions. You got to ask a couple questions about mania. The number one question to ask, and it'll be right 85% of the times, if they answer yes to this question, 85% of the times it indicates that they've got a bipolar disorder, is that do they feel like they have a decreased need for sleep? That is 85% of the time lines up with bipolar disorder. And you got to make sure they're not, using a bunch of meth or something at that time. But decreased need for sleep is the big one to ask about. Then you can ask about kind of grandiose behavior, spending lots of money, running off with the family fortune and starting a new business in another state, running off and starting another family, or it's all kind of in a cultural context. So if you have an Amish patient and they're not going to be running off and starting a new family in another state, but if they're taking out the horses in the middle of the night and running around the field, that would be, it's kind of funny, but it's all kind of within its cultural context. So you have to, whenever you see your patients, you got to kind of be aware of that.
Quick question. So you said decrease the patients that say, "Oh yeah, I stay until 5 in the morning."
Yeah.
Watching TV or playing video games.
Yeah.
Is it a specific time period, like 2 days, 3 days?
Yeah. So, and especially for the decreased need for sleep, is that the person stays up and they don't feel tired. So they feel like they can stay up all night, and then when morning they just feel still wired. So we start looking at 4 days, 7 days out. That's when we really start to be concerned. A day, if somebody says, well, every once in a while I'll be up all night for a day or two, that's probably more likely to be some anxiety, or just that's also the course of depression. In depression we see difficulty falling asleep and then early morning awakening. So when you're asking questions about sleep to your depressed patients and they say, it takes me an hour to fall asleep, and then like clockwork, 3 a.m. I'm up and I can't fall back asleep, that's really indicative that this person probably has a depressive, it's got some depression going on underneath. There's another question? Or no? Okay. So, we've ruled out that this person is bipolar, or we think that we've ruled out that they're bipolar. What are we going to do to treat them? And I guess one thing I'll say before we talk about treatment is the reason that we ask about those bipolar questions is there is a certain percentage of patients that have depression that SSRIs and certain antidepressants will cause this, will cycle them into mania. One thing that you guys should look out for is that it's not that you'll give them Prozac and then they'll come in, not having slept for 7 days and looking really floridly manic. It might be that you give them the medicine, instead of getting better, they just get more irritable and they're just, meaner. And so it can be pretty subtle. So you think, okay, well, I started this guy on this medicine. He didn't seem to get any better. It seems like his depression is getting worse and he's more irritable. I'll go up on the dose. And you wind up kind of making the problem worse. So we see that pretty frequently. People that come into the clinic that have been put on an antidepressant, the provider was thinking that it's helping and the dose has been escalated, thinking that, okay, this guy's getting worse, like I need to get on top of it. And a lot of times it's the medicine that's causing it. So when you're assessing if an antidepressant is making somebody worse, don't just worry about mania, but worry about just increased irritability, increased mood lability. Those kind of things are probably, you'll see much more frequently than someone coming in floridly manic. I think I've seen maybe 1 or 2 people that I've given an antidepressant to, and they've actually just made them manic. And it's only about 5% of bipolar patients that exhibit that. So it's not everybody either. So there's a lot of bipolar patients that do have a true bipolar illness that can take antidepressants, SSRIs. So the big study that we typically use for looking at an algorithmic approach to treating depression is the STAR-D trial. This was 3,600 patients, started off as like 44, and they lost some to follow up. 41 clinical sites, about half of them were primary care offices. And what they saw on this is that there was no difference between the patients that were treated in the primary care office and the patients that were treated in the psychiatrist's office. The responses were the same, the relapse, the remission rates were the same. So you guys are doing the same thing that we're doing. And what winds up happening is you guys probably actually see the same volume of depressed patients that we wind up seeing. So we're really in this together. To be in the study, you had to not have been tried on the first 2 levels of medication. And we'll talk about that in a second. So these are people that are newly depressed, most likely their first episode of depression. So this is not all that similar to patients we see in the clinic. I mean, you guys have patients that have been tried on, everything under the sun. Those patients are going to be much more difficult to treat, and they're going to require kind of a much more thorough psychiatric evaluation. And those are the ones that are really going to need to refer to psychiatry to figure out, 4th, 5th line of treatment choice. The ones that that you'll see responses from are going to be these first episode of depression. One thing that made this study different is that the patients had some control over how they would proceed. So this wasn't just a strict randomized study. They created a name for it, and it was, equipoise stratified randomization. So the patients could, once they got to a certain step, they could say, okay, one of these 3 or 4 treatment options would be acceptable to me. And then based on what they found was acceptable, they would randomize to those groups. So you had, one thing that you see in mental illness is that you really need a lot of buy-in from your patients. So this kind of one way to get some buy-in, and you guys can use it in your clinic. So the remission rate, cumulative, for the patients in this study was about 67%, which is not all that great, I think. The first level, so this was patients that were put on the first medication, which in the study used citalopram, Celexa. They only about 36% received got to remission. And then after each level of treatment, the rates of remission went down. So what that tells you is that the more things you try, the less likely it's going to work. So if this guy has failed one thing, he's failed another, you have to, especially if it's the first time you've seen him, you've got to You've got to set expectations that, hey, you failed these other things. We've got this medication out there. There's a shot this could work, but if it doesn't work, we got to start thinking about other things. So it's not going to serve anybody well to say like, oh, this is this great medicine. We'll just give this and it'll kick this depression, because we know that that's not true. And by the time you get to level 4, only about 13% of those patients that reach that point wind up getting remission in their depression. So here is the algorithm here. You start with Celexa, and then you usually treat it for 12 to 14 weeks before you decide you need to switch. You move to Wellbutrin. You can move them to cognitive behavioral therapy, Zoloft, Effexor. So the patient needs to make a decision of, okay, this medicine didn't work. Do I want to switch, or do I want to add something to it? And what the study found is that people who decided to switch, they had higher depression scores, they had a higher description of side effects, which makes sense. If somebody doesn't like how they're feeling, they're not going to want to try to add something else. They're going to want something completely different. What was interesting is that the improvement, the rate of remission was no different in the folks that switched strategies in level 2 or augmented things in level 2. So if a person has failed your first option, and you're just trying to figure out if you're going to augment or to switch, either way you go is going to have good evidence to say that you're right, which is a good thing. So you've got options, and you can present those options to the patient. Yeah, go ahead.
When people after level 1 with their options to titrate up to Celexa, or is it like after level 1 and they're already maxed out before you're level?
Yeah, in level 1, they were there for 10 to 14 weeks. It was right around 12 weeks. And you tried to get them on the maximum dose before it decided to fail. And I'll actually show the doses in a couple slides from here. So you want to, before you say this agent is not working, you want to make sure you get the most effectiveness out of it. So that requires time and a maximum dose. Another question?
So, just so I'm clear, so on level 2, you can either switch to a different medicine or add a second therapy, and you got the same remission result.
Exactly, yep. So the folks that failed Celexa alone and then switched to Zoloft, and the people that failed Celexa alone and then kept on the Celexa but added Wellbutrin or bupropion, the remission rates was significantly the same. So there's no difference between the two. Yeah.
Is there a reason that they're doing it? Is that the next step after development, or is that just arbitrary?
Yeah, so it's largely arbitrary. And what you'll find, and what we'll talk about towards the end, is that when we're looking at antidepressants in the SSRI class, SNRIs, which are like the Wellbutrin, duloxetine, Cymbalta, they are all similarly effective, all similar side effects. So what we'll see after this is that you don't have to start with Celexa. You don't have to start with what we show right here. You've got good evidence to see that as long as you start as something in that class and kind of follow this general algorithm, you'll do well. Any other questions? So, each level you go on, you're going to expect that if they fail a level, the next time they go, there's going to be less chance of full remission of depression. By the time you get to level 3 and level 4, that's probably when you should be thinking about sending them over to us. I don't know how comfortable you guys feel with using MAOIs, but I'm guessing you probably don't have many patients on MAOIs in your clinic. And we don't either, but they're not that scary once you start to learn about them. And they can be really helpful for folks with severe depression. In level 3, what we see is that one of the augmentation strategies is using thyroid hormone or using lithium. You guys are going to be much more comfortable with using thyroid hormone than lithium. You don't have to check a blood level. You don't have to monitor, creatinine function. On the flip side, I can write lithium scripts all day, and it doesn't faze me. And I write very few scripts for thyroid T3. So the big takeaways from this study were that folks that demonstrated remission, you needed about 7 weeks on a medication to show a response. And then of the folks that went on for their depression to remit, 40% of those actually needed more than 8 weeks. So if someone comes back at 5 weeks, 6 weeks, and tell them they're feeling no better, as much as you can, tell them, we just got to wait. We just got to wait. And that's going to be important on the front end. So you don't send someone out the door with the prescription and say, hey, this is going to make you feel great in a week or two. You got to set the expectation that, we'll continue to see you in the clinic. Even if we don't make a medication change, it's important for you to come in and tell me how you're feeling. But we got to wait. And that's, so you want to make sure that they're kind of doing things to stay active. That's kind of some of the other therapies that you're going to talk to them about. So you need time, and you need an adequate dosing. So you don't kind of stop right at 10 milligrams or 20 milligrams of Celexa. This study actually went up to 60 milligrams, which we now don't use because it caused QTC prolongation. And then, like we said, if you switch things, every time you go to the next level, you wind up getting less of a chance of full remission. But the good news is that after the first 2 levels, about 50% of the people got better. So about 50% of the people that you're going to treat are going to require this first or second step. Those other people that are not, that aren't going to get better, those are the ones that should be referred over to psychiatry. So here are the average doses that they used that were effective in the study. 40 milligrams of Celexa, that's a pretty standard dose. It's kind of, we usually give folks 20 or 40. Wellbutrin, bupropion SR, that's the once-a-day dosing. So you're going to probably use the 300 milligram dosing. Zoloft, you could do 125 or 150. Effexor, 200, or comes in a 225 form. Buspar, one thing that showed in the STAR-D trial was that when they adjuncted Celexa with bupropion or Buspar, the people were better able to tolerate Wellbutrin versus Buspar, even though the rates of remission were the same. So I don't use much Buspar in my clinical practice. It just doesn't seem to be that effective, and I don't have much luck with it as an adjunct. Remeron, this is kind of at the higher end of Remeron dosing. I think the max is 45. So we also know that at the higher doses, when we give it to patients to help with sleep, that the higher the dose goes, the less sleep effect it has. It's the most drowsy at 7.5 milligrams, which is half I think the smallest pill they make is a 15. Your TCA at about 100 milligrams. Lithium, 900. That's like 900 to 1,200 milligrams is what you're going to give a bipolar patient. More recent studies have showed that you really just need a blood level about 0.3. So you could probably get away with about half. So just, a 450 milligram tablet of lithium in the evening to prevent, upset stomach and nausea is likely to do the trick for depression. And your T3 and your TC or your MAOI there at the bottom, which you guys are never going to use for good reason. So one of the other algorithms came out of Texas. And this is this medication algorithm project. It's pretty much the same thing. So you see the first step is that you do monotherapy, and you can pretty much pick any SSRI, an SNRI, Wellbutrin, or mirtazapine. People that respond a little bit are going to adjunct, which makes sense. If you don't respond, then you're going to switch classes. So try something with a different mechanism of action. And then for those folks that don't respond, you're going to adjunct again. And then at the end, then you're going to start to add kind of these more atypical combos, including adding an atypical antipsychotic to your SSRI. How often do you guys wind up using like Risperdal or Seroquel or Abilify in your clinic? I see mostly shakes. Does anyone ever prescribe it? Does anyone prescribe the antipsychotic? Inpatient? Okay. Yeah, go ahead.
Yeah, I have a schizophrenic guy. It's a special situation, but he doesn't believe he's actually schizophrenic, so I'm Seroquel for sleep.
Okay, yeah. Yeah. What dose of Seroquel are you using?
I started with 50.
Okay.
And then they were really sleepy. Based on one of the other cyclists recommendations I went with, 300.
Yeah.
And he still sleeps all the time. We dropped it at
You're just good there.
Yeah.
Good enough. Good enough. Yeah.
Still refusing to see psychiatrist.
Yeah. Well, you can give me a call and we can come up with some other options. But yeah, atypical antipsychotics can be used as an adjunct for depression. But the one thing you worry about that, I always get called from family medicine, internal medicine, is that it causes so much weight gain, increase in lipids. The metabolic side effects of antipsychotics are horrible. We used to go to like 7 counties and everyone would be kind of standing in the waiting room, ticking and smacking their lips. We don't see that anymore. We just see people that are 200 pounds overweight. So we've changed, we've exchanged some side effects for other things, essentially. But yeah, it's something that you guys are kind of unlikely to use, but there's good evidence to show that using some atypical antipsychotics is helpful in depression. So we've given them a treatment option. What do? We got to come up with a plan. You're going to work on developing that alliance with the patient. So you're framing the discussion, and you're going to say, okay, how are we going to move forward? What are your expectations of treatment? What are your expectations of getting better? You're going to be honest with them that says, hey, we got to wait. You got to take this every day, and we got to wait, 6-8 weeks until we start to see a response. But if you have problems, you give me a call, and before you stop the medicine, you give me a call, and we'll talk about the side effects. It's really helpful to talk about it in terms of we instead of I. The patients don't feel so isolated. And at the same time, you don't want to say, hey, this medicine works for everybody. I think it'll work great for you. You got to kind of remember that each person is an individual and tailor treatment to that effect. So your plan for follow-up, you're gonna kind of set expectations with them. And ideally, you're going to see them back in 4 weeks. Is that doable in your clinic? Okay. And a lot of times they'll come back in 4 weeks and they'll tell you, I am no better. And it's really frustrating, especially to sit there and realize, okay, this person's just started this medicine. They probably picked it up a couple days later. It's only been maybe 3 weeks, 3.5 weeks. So you got to be honest with them that says, hey, it's handy if you can do a PHQ-9 or a scale to see maybe there's a couple points you can use that to kind of instill some hope in the patient. But you really got to tell them that, hey, it sounds like you're doing a lot of things right. I want you to keep those up. And I think we should really stay where we are and wait a little bit longer until we decide to change or, add medication. It's really tempting if something's not working to switch it, because it sucks having a patient leave that feels like they're being helped. And, I feel that frequently. But we know that these things take a long time. And we know that we got to wait about 7-8 weeks to really say, okay, is this going to be effective or not? And sometimes, I'll tell them, hey, go ahead and call me in 2 weeks, check in, see how things are going. If need be, we can make a change on the phone. So after that, depending on how they do it, 8 to 10 weeks, then you're going to have to decide, okay, how frequently is this person going to be following up? Do they do great? Is the depression in remission now? And when it is in remission, you have to think about, okay, what are we going to do for maintenance for this person? And you want to make sure that they know that even if they're feeling better, they need to stay on this medicine. And you're going to ask them to stay on at least 6 months. We look at about 6-9 months, sometimes a year, before we decide, okay, then we'll try to taper it. But one of the things you don't want to do is you don't want them to feel better and then stop taking it, and then several weeks later start to feel worse again and have to start the cycle over again. And we know when that happens that the second time they're tried on a medicine, their response rate is not as high. So we know that someone who has a depressive episode is more likely to have a second one. And we know that if you start something and stop it, your response the next time around is not as good. So if we can limit that, we'll be setting ourselves up for success. Just a couple quick little pearls that are helpful. Most common reason to stop things is nausea and vomiting. You can let them know off the bat that says, hey, there's a fair shot this is going to make you feel sick to your stomach. If you can just get through it for those first couple days, it's going to go away. For the most part, people's nausea and vomiting from SSRIs, from SNRIs, goes away after about 5 days. So if they can get over that hurdle, then they'll be good. You can say, hey, I can even give you a couple PRN Zofrans to take home. You don't have to worry too much about like serotonergic, serotonin syndrome with SSRIs and other serotonergic medications. So you're good from there. So that's something I'll always say, especially if they've had a history of being nauseous from medication. Say, you can either give me a call or we can give you some Zofran to take with you. all those second-generation antidepressants we talked about, Zoloft, Prozac, Celexa, Lexapro, and then the SNRIs like Effexor, bupropion, and they're all similar effectiveness, all similar efficacy. So if you find a patient that has a certain, they've been on something in the past, or a family member had a really good response to this and they want to try it, and if it seems reasonable, it's always nice to have the patient's buy-in and start there. So of those antidepressants, the one that seemed to work a little bit faster was Remeron, mirtazapine, and they started to see some effect at about 2 weeks. So we're not talking about a full remission in 2 weeks, but if you're really worried that this person is is in a bad spot and you want something as quick as possible, and they can tolerate the fact that it is going to increase their appetite, then Remeron is a good place to start. Really concerned about sexual side effects. I have patients all the time who, at the end of the visit, say, hey, things have been going really, I had to stop this medicine because, I'm not able to have sex with my wife or whatever. So it's important to gauge if this person is sexually active. If you've got a 30-year-old patient, it's going to be more important than probably your 75-year-old patient, maybe, I don't know. But telling them about sexual side effects is going to be really important. And if they have problems, have them call you, so you can try some adjuncting. A lot of times we'll use Wellbutrin as an adjunct to help with some of the sexual side effects. And then some medicines have less sexual side effects, like Remeron has less sexual side effects, and Wellbutrin has few, if any. So if a person is really concerned about that, your best starting places are probably going to be Wellbutrin and Remeron. Of course, you see more weight gain with the Remeron. Of the SSRIs, you see the most diarrhea with Zoloft, sertraline. You want to caution them not to stop the medicines abruptly, especially if they're taking Effexor or Paxil. Those medicines have short half-lives. They will feel miserable if they stop it suddenly. Medications like Prozac, if they miss a dose, they're probably not even going to notice it. But if you miss a dose of Paxil, you're going to feel bad. So make sure the patients are aware of that. I actually don't use much Paxil at all in my practice in the clinic. Has the highest sexual side effects out of all the SSRIs. Has a withdrawal syndrome. So unless there's good evidence that you can use it in some pregnant patients, but even now it seems like there are better options. So I would say out of all the antidepressants, I use paroxetine the least. So to kind of sum up what we should do is you want to use a formalized instrument to figure out if this person's depressed or not. We want to screen for a couple of other things that are going to increase their risk or their poor response. We want to treat it, and we want to treat it to remission. We don't just want to treat it to response. And we want to set up a follow-up plan.